polarized atria contracts, all that. Okay, so that I'm leaving it up to you. And then it comes to the AV node, then it innervates or it depolarizes papillary muscles before the ventricles. Papillary muscles are contracted, closing the AV valve. I need to see that, all right? So what causes the AV valves to close? Papillary muscles, right? Contraction of papillary muscles before the ventricles contract. Okay, that is not given in the figures. You have to write it. Okay, don't forget to write that. All right. So once the ventricles contract, what's happening to the pressure? Oh, no, that's my drawing. Okay. Once the I said that is really good drawing. Okay. So once the ventricles start to contract, what happens to the pressure? Pressure is going to rise, right? The ventricular pressure increases. Now let's see what's happening. So here you have the pressure is increasing. So when the pressure increases, it is going to open up these valves. Can it open this valve? No, because they're still attached to the papillary muscles. The papillary muscles are still contracting, so this cannot open, and we don't want them to open, right? If they open, this is going to go back into the atria. We cannot have that, right? So this is going to push open these valves, and it's going to go up. This is going to remain open as long as the pressure here is higher than the pressure here. Okay? So what is the pressure in pulmonary artery? No, pulmonary artery on the right side. 24 over 8. Okay. And what is the pressure in aorta? 120. So we have a range. Okay. What is this range? So we'll talk about it. So as long as these are squeezing and it is higher than 20, higher than 8 and higher than 80, it's going to push, right? Once this starts to relax, right? So now this has gone through ventricular repolarization. So ventricles start to relax. Once this relaxes, the blood is going to come back, fill the cusp, and close, right? So now the semilunar valves are closed, and this is again isovolumetric, right? When everything is closed, all the valves are closed, they're closed chambers, you have the minimum amount of blood remaining. That's called as end systolic volume, and then the whole cycle starts again. Okay. Can somebody summarize this? So write it in 4 parts. What are the 4 parts? What are the 4 phases?
Ventricular,
Ventricular, filling,
isovolumetric,
contraction phase,
ventricular ejection,
and then 4th one is isovolumetric relaxation phase. So write down number 1, ventricular filling. Go ahead, write it in your own words. filling? Okay, so blood is filling, okay?
Ventricle relax.
How? Already? How did atria go into systole so soon? Yes.
Ventricle relax. AV valve open. Semilunar valve closed. And blood fill the ventricle.
Good. Good. We start from there. So AV valves are open, right? Semilunar valves are closed. Blood is filling from the veins and it is filling passively into the ventricles. Number 2. How? No. They're still with the ventricular filling. Number 1. So blood is flowing passively. Then what happens? SA node fires. Good. So passive filling, okay, followed by SA node starts to depolarize. Then what? Leading to atrial depolarization. And then off. So atrial contraction. Good. So you have to write all this. You cannot jump to atrial systole or ventricular systole. No, there are a lot of things that is happening. What is happening to the valves, right? What is happening to the pressure? What is happening to the electrical activity? And that is what is controlling this whole thing. All right, next. AV valve is already open. Right? AV valve is open here. Okay, ventricle is filled, okay. Okay, so how does that happen?
Pressure builds up.
SA node, the message from SA node has reached the AV node. Good. From AV node, it is going down to bundle. Good. From bundle, it is going to bundle branches, and then what? Between Purkinje fibers and bundle branches, what is innervated? Papillary muscle. So you have to mention that, papillary muscles. And what does this do? So if that closes, the AV valves. And then you can say, the ventricles are, and you can write here, from papillary muscles, it is now going to, or you can say here, Purkinje fibers. Okay? Closes the AV valves, the ventricles, now what is happening to the ventricles? Ventricles are contracted. Then we come to the next stage. So now you know you have to go step by step by step. If you jump ahead or miss that flow, your heart is going to go into fibrillation. And if I'm asking the question, Rosalie, if I'm asking this question, I don't want you to just write this. No, I want you to write the whole thing. Okay, so let's go into this. Volumetric contraction phase. What's happening here? with what is isovolumetric, right? So start from there. What does isovolumetric mean? Isovolumetric contraction?
Valves are closed.
The valves are closed. Both sets of valves are closed. And what does that mean? Ventricles are closed chamber. And they're completely closed. Now talk about the volume. They are filled with maximum amount of blood. So it has maximum amount of blood, which is called as EDV. So, how do the semilunar valves open? The pressure, right? So say that the contracting ventricles need to increasing pressure. So once the semilunar valves are open, the blood is going to. That's the end result. That's the end of the fourth phase. Where is it going now? Good. Which are these? All right, Klaus, you tell me what is happening after this.
Sorry, in the ventricular contraction?
No, are we done with
Okay.
isovolumetric? Are we done? What else can you write? You're making me fall asleep. Okay. I want you guys to talk.
Oh, like, after all that, the valve.
After this, what is happening?
Oh, the valve, after all the pressure builds up the valve, the semilunar valve will open.
Okay, so semilunar valve opens, okay, and the blood flows into,
Pulmonary,
good, into pulmonary artery or vein? Artery, and air. Good, okay. Then you can say about ventricular ejection, so blood is flowing. Then you can write this step there, that's fine. Okay, so how long will the blood leave the heart? So what is happening in the EKG? QRS, end of QRS was this, right? And then you're going to go into T-wave, which is ventricular repolarization. So while this is happening, so the blood is flowing, so we have the T-wave happening, which leads to ventricular relaxation, right? So repolarization. So this is followed by ventricular relaxation. So that is ventricular relaxation. So once the ventricles relax, what will happen? Atrium is gone. Atrium is like that. We don't talk about atrium. So ventricular repolarization, so ventricles are relaxing. What happens when the ventricles relax? The pressure is,
Drops.
what happens to the pressure? blood is going to come back, okay? And when it comes back, it's going to close the semilunar valve, okay? That's your dub sound. So as the pressure is dropping, the valves will close. And I'm going to talk about this. So leading to dicrotic knot, I'll tell about what is dicrotic knot. Alright, so now again, we have a closed chamber which is called as isovolumetric relaxation phase. So in this, all the valves are closed again, right? Whatever amount of blood had to go has left. So what is remaining now? That's called as ESB, right? So that is called as end systolic volume. And then the blood flows through the body. Now we talk about the blood flowing through the body, and then the full cycle repeats again.
So what did it say underneath the valves closed for ventricular
Blood
ejection?
flows into pulmonary artery.
Dichrotic.
No, ventricular ejection, what does that say after valves are all closed, or valves all closed? Dichrotic knot?
Notch.
Knot? Thank you.
Dichrotic knots, I'll talk about that. EEs is the
For
name.
the isovolumetric relaxation.
We have to know all this by Friday.
Yeah, and then I'm saying blood flows to whole body.
So can somebody summarize this whole thing? Be a lady? Yeah. Can somebody summarize this, the whole thing?
I have a question.
Yes.
You know, for number 3, you put that the pressure is low, right? But that's like the
No,
ejection.
pressure is high.
Yeah, okay, so I'm just clarifying. So the pressure being low would be for step number 4, right? Not for step 3.
No, it will be step 3 because when the pressure falls, so we are talking about blood flowing into pulmonary artery and aorta. Meanwhile,
So when
ventricles
blood's
are-
flowing into the pulmonary artery and
The pressure is
aorta,
high.
the pressure is high,
Yeah.
because we're doing the ejection.
Right.
Right, so then during the relaxation phase of number 4,
No. Relaxation phase, so this is isovolumetric relaxation phase before it is relaxed completely. So we are still here. So once the blood is flowing, right, the T wave is going to start. So ventricular repolarization is going to start, which is going to cause the ventricles to relax. That is going to cause the pressure to drop. And when the pressure drops, the blood comes back, closes the valve. Then it enters the isovolumetric phase. Isovolumetric is when it's closed chamber, right? In order for the valves to close, the pressure has to drop.
I have a question for number 2. The vessel valves, they lay open on that place or no?
They're looking, I mean, it's kind of leading into that. You can let them do that question. As long as it's in the sequence. All right, no summary, go ahead. Summarize the whole thing. You've been talking here, so go ahead.
Okay, so ventricular filling,
We start with ventricular filling, okay?
it
All right,
starts,
so now let's talk about all the valves and chambers and blood vessels. Go ahead, ventricular filling.
there's passive filling, so it fills up with blood.
Fills up with, what fills up with blood and how? Nowadays, like laughing. Go ahead.
The atrium, the right atrium fills up with blood from the, what is it? The SA nodes?
Help it. Help it.
Traveling down the atrium.
Okay, so two different things. SA node is a electrical activity and filling is a mechanical activity. So don't combine them in one sentence.
Through the vena cava.
Okay, so through vena cava, superior and inferior, and on this side, that's the first step. It's, what's, the status of these valves here? Are they open or closed? They're open, so what is happening to the blood? Blood is just passively flowing through, right? That time, SA node starts to fire, right? So first you write about the passive flowing, and then you say SA node is beginning to fire. SA node fires, that leads to atrial depolarization. That is then the next step would be atrial contraction. So it's pushing all the blood into the ventricles. Good. By that time, the electrical impulse has reached the AV node, and then you can go into it goes into the bundle, and then is it Purkinje fibers? Before reaching the Purkinje fibers? Okay. So bundle branches, and then what?
Papillary muscles.
Papillary muscles. Good. Papillary muscles and then Purkinje fibers. So once the papillary muscles are depolarized, what happens? Okay. Elena, go ahead.
It contracts.
It contracts, and that leads to
Closing of the
closing of
AV
the valves.
valves.
Right. And then you can start with the second part, right, which is isovolumetric contraction phase. Because isovolumetric means closed chamber. The valves are closed. All the valves are closed. Right? So the valves are closed. Now you have the ventricles filled with blood, right? Maximum amount of blood, and that is called as
ADV.
right? That is your end.
That is the volume.
Right. And then what? The pressure builds up, and then that pushes the blood. Can it go back into the atria? No, right? Because these are still closed, so they're going to push open
Semilunar valves.
right? And the blood flows into the pulmonary arteries and
Aorta.
Right. So that is your number 2, right? That's your ventricular ejection, right? So as it is flowing out, now what is happening? You can talk about AV valve, I mean SA node, it's going to repolarize the atria if you want, right? You can say QRS wave, it leads to atrial repolarization, atrial relaxation, right? Or not, it's up to you. Atrials is going to relaxation immediately, right after they do their job, right? They don't involve atria too much. So once it goes here, the blood is flowing out, right? The pressure, as long as it is exceeding that of the pulmonary arteries and the aorta, it's going to push the blood. Right? T wave happens, and the ventricles begin to repolarize, and that is going to lead to ventricular relaxation. Right? That is going to lead to your 4th part, right? So once the ventricles relax, what happens to the pressure?
It drops.
It falls, and the blood is going to stop here. The blood is going to come back and close the SL valves. Okay. Now we have ventricles, again closed chamber, right? That is your end. Systolic volume, that is your isovolumetric relaxation phase. Okay, so dichotic valves, let's talk about that. So we have so as it is going up, right? So we have the valves here. So as long as it is pushing and it is going up, right? Once it starts to relax, the blood starts to come back. Okay? A lot of pressure here, right? So as it is coming back, it's going to fill the cusp and close, right? The blood is still flowing back. So as it is coming, it hits the valves and then ricochets. So that momentary rise is called as dichotic valve. Okay. And that is seen in the graph. I'll show it to you just a minute. Is this clear?
The blood hits the closed semilunar valves.
Right. And bounces basically. Okay. have, this is the cardiac cycle. Okay. Here you can see the filling and like the whole heart, what is happening in the heart. This is your EKG. This is the heart sounds, right? Now, this side, this is the left side. And let me make it a little bit better. Alright, so here you have, this is the left side. This green is the ventricle. This one here is the left atrium, right? And this one is the aorta. This is the pressure, right? In the beginning, it's 0, right? In the atria and the ventricles, not the aorta, right? Aorta is between 120 and 80, right? So as this is pushing, there is a slight increase in aorta. We don't have to worry about that. So think about this. So this is your atrial pressure, right? So when we're talking about it squeezing, the atrial systole, only this much. That's all you need, and to push all the blood. It's not really that important. But look at the ventricle, right? As the ventricle is filling, or as the ventricle is beginning to contract, look at the pressure, right? It goes all the way from 0 to about 120, right? Why 120? You can go higher than that, but you don't need to, because this is the aortic pressure, right? So at 80, the valve is going to open, okay, the semilunar valve, and the blood starts to flow. This is your end diastolic volume, right? That's the maximum amount of volume. So as the pressure increases, the blood is going to be pushed out, right? So it is going to be pushed out till it matches the high part of your aorta, right? And then once it starts to fall down, there's your dicrotic tranche, right? So the blood is going to, that is your last bit, right? So that is the end systolic volume. Blood is still flowing out, and once the valves close, the pressure is still falling down, right? But in the aorta, it still remains the same. So there is a momentary rise in pressure in the aorta, not the ventricles, right? Because it's hitting and then going back into the aorta. That's your dicrotic tranche. Do you understand this? Let me go back to,
So will you do the atrial pressure too? So this one.
do we need atrial pressure?
Well, I just want it. Okay, fine.
Here it
that's
is.
fine, fine,
Here it is.
fine. Okay, but.
So if you look at the P wave, let's see. So there's your P wave, there's your P wave. At the end of P wave, you have the atrial contraction. Okay, so here you have, this is the P wave, right? And there's your contraction. End of P wave, right? So in the middle of the P wave, it's not contracting, but it is depolarized.
So the pressure builds up slightly too with the atrial pressure.
Oh, yeah. Because they're next to each other, so there is some. Yes? Let me show you. Here's another picture. Okay, so this one shows, this is the left side, this is the right side, right? So you have, look at the pulmonary trunk, right? So it is from 8, somewhere between here, somewhere between here and here, right? So it's really low pressure, right? So here you have right ventricle, and as long as it meets that 28, the blood is flowing. Okay? It is the same amount of blood, the volume remains the same. Are you guys even paying attention to I even talk, or I can shut up? Okay, no, okay. Yes? You with me? Okay. Don't wander. Don't let your minds wander. This is important. So this is low pressure, right? This is 24/8, and this is 120/8. Look at the pressure difference, right? But it is the same amount of blood that is traveling in both sides. Same volume is the same. Okay? So I like this picture as well. And then then if you compare this, so here you can see the filling of the blood. So here you can see, so this is the end diastolic volume and this is the end systolic volume. Okay? And what is going out, that is your stroke volume. I'm not done yet. So, you can look through this. Then we go into cardiac output. So what is cardiac cycle?
Electrical, heartbeat.
Okay, so all the events that have taken place in one heartbeat. Good. And now we go into cardiac output. Johnny is going to come and teach here. Okay, so be careful.
Okay.
So cardiac output is amount of blood that leaves the heart in 1 minute. Okay, and we saw in cardiac cycle that EDV minus ESV, right? Maximum amount of blood minus minimum amount of blood, that's the blood that has left the heart, right? That we call as stroke volume. Right? So this is per cycle, and this is per minute. Okay? If the heart beats 72 times, if we multiply this times the heart rate, we get cardiac output. So if we have about say 120 milliliters minus 50, then we have about 70 milliliters of stroke volume. And that if we multiply with heart rate, we get about 5 point something 04, I think, 04 liters, about 5 liters for 5,000 milliliters. Okay, so this is per minute. So stroke volume times heart rate. Okay, so stroke volume. So what are the factors affecting stroke volume and heart rate? Okay, so suppose we have, what is stroke volume?
Amount of blood pumped in one heartbeat.
Okay, amount of blood in one heartbeat, right? And that we can calculate by knowing and maximum amount and minimum amount, right? So we have EDV and ESV. Suppose we increase the EDV, what will happen to the SV? Okay, suppose EDV is increased, what will happen to the SV?
Increase.
Okay, suppose we decrease the SV, what will happen to the stroke volume?
Increase.
Increase, right? So suppose we decrease the EDV.
Decrease.
Increase or decrease?
Decrease.
Decrease.
And if we, let us say increase earlier, if we increase the SV.
Increase.
Alright, so we want EDV to increase and ESV to decrease. Does it make sense? 12 minus 5, this is going to increase, right? Suppose I have, this is the same, this increases, now I have decreased, right? So this is increase, this is normal, right? So if you don't remember this, then just put some arbitrary figures, just 10 and 5 and then. If it confuses you, if you don't want to visualize. Okay? Alright, so we want this to be higher and this to be lower, right? Because we want this to be high. So this is what is going to the blood, to the body, right? So we need blood for the body. Right? No.
Well, I'm kind of, so the 120 for the EDV and the 50 for the ESV, those are like common averages,
Just
right?
yeah,
Okay.
generally. Everybody will have it.
And this is important, like the cardiac output is important to cardiologists because it shows the parts of the heart maybe, is it too low or too high?
There you go, yes, alright. So we'll come to that, we'll come to that. So stroke volume, right, depends on how good your heart is, yes? Right? So suppose the heart is really toned, right, your skeletal muscles, right? So it is like stretching and contracting, stretching, contracting. So as long as it stretches, it's going to contract really forcefully, right? So the more it stretches, the more it contracts. It's like a rubber band, right? So you stretch it, it's going to come and close it, right? So if the heart muscle is nice and toned, right? When you're exercising, this is a muscle too. This gets toned as well, right? So we talk about cardiac exercises or cardio, right? What is cardio doing? It's toning your heart muscle, right? So you are increasing your EDV, right? So we'll talk about the factors affecting EDV. Now, if, okay, let's talk about that. So there are 3 factors. The first one is called as preload. Then we have contractility. And the third is afterload.
Completely out. One repeat. Just percentile is very sad.
This all should have been in the book, all the things that I spoke about. Yes? Now it makes sense? I hope it does. Now if you go read it again, it will make sense. I make it like really, really detailed, but you will get something out of it, right? Yeah. So ED, I'm sorry, stroke volume is affected by these 3 factors, right? Preload, contractility, and afterload. So we want EDV to be high, ESV to be low, right? So EDV, what is EDV? Maximum amount of blood, right? If we have more blood, the more blood it can go out, right? So if it is pushing more blood, then ESV is going to go down, right? So that's what we want. Okay. So preload means how much blood is coming to the heart, right? Preload, right? So before it contracts. So preload is affected by things like venous return, and also it's called as Frank-Starling law of heart, meaning the heart muscle can stretch, and once it stretches, it's going to pump harder, right? So that depends on venous return. Okay, venous means veins, right? Return means coming back from the veins. Veins are, we're going to study this in the next chapter. Veins are the reservoirs for blood, right? And they don't have any pressure. They don't come back by pressure, but it mainly depends on your skeletal muscles, right? So skeletal muscles, as they squeeze, they bring in the blood back, right? So the better your skeletal muscles, the more it is going to pump back, right? So again, that depends on how the skeletal muscles, how toned your skeletal muscles are, right? Goes back to your cardio, right? So both. So how much can it stretch depends on how good the heart muscle is, right? So preload is good. So we want high preload, we want high EDV so that the stroke volume is higher, right? So that is your preload. Contractility refers to when it stretches, it contracts pretty strong as well. So again, we need that contraction. left or the right side? The left, right? So we are talking about the left side of the heart, right? So that's your blood pressure on the left hand side. What's the blood pressure on the right hand side? So this is 120 by 80. What is the blood pressure on the right hand side?
24 by 8.
Look, 24 by 8. Don't forget that. Alright? So if your blood pressure is high, right? So instead of 120 by 80, suppose a patient has 150, say by 110. Okay? I'm going to go back to that picture. So now, in all probability, a person who's having a high blood pressure is also going to have not a very toned heart, right? So stretching is not possible. EDV may not be high, right? The skeletal muscles may not be bringing as much blood as we want. So blood pressure is getting high. Blood pressure refers to the arteries, not the heart, right? So this is the pressure in the arteries which the heart has to overcome, right? So now instead of having it here, we have it here. Does it make sense? So the blood has, the heart has to pump has to contract all the way till here and then here in order to push the blood. Does that make sense? Right? So instead of 120 by 80, now we are talking somewhere here, right? 150 by 110. So this whole thing has gone up. Okay? And in order for you to have that stroke volume, the heart really has to work really hard, right? It has to work overtime. So over time, the heart gets hypertrophy, right? It's going to make itself bigger so that it can push the blood. It can become flabby, right? So it may go into cardiomyopathy, all kinds of problems with the heart. So afterload, we don't like afterload, right? So afterload causes the ESV to increase. Okay, so EDV may remain the same, most probably it is going to go down. And what is going to happen to the stroke volume? It will go down. Right? So this is directly related to the blood pressure, high blood pressure. Okay? Did that answer your question? I forgot what your question was.
I also forgot my question.
Okay, good. Ask me again later on if you. So that is your stroke volume, right? Heart rate is controlled by sympathetic nervous system, right? So you can increase and decrease heart rate very quickly, right? By sympathetic neurons, epinephrine, norepinephrine, right? Even glucagon can affect your heart rate and so on. So if you remember epinephrine and norepinephrine, I'm happy. We want an EDV to increase and ESV to decrease. That's why I love cardio exercises. I need strength training, but I love cardio. You hate the cardio?
Well, I remember in school they used to focus on balance.
Schools are, yeah, we're talking about school. I'm talking about enjoying yourself, doing cardio. Dancing is a cardio.
Something else is cardio.
So what
Something
did you
else
do
is
for
cardio.
in school? What did you do for cardio in school?
We saw strength training. Oh, strength training is just dumbbells.
It's more than that, but okay.
What do we?
I mean, it's a mixture.
So mostly that.
Yeah. Mostly weights, but for
it
me, like, I
obstacles?
include cardio.
Mm.
No, it says you have to
Right, but
run.
those are two different things. Cardio is.
And strength training.
I do
Strength training is
For the,
not like,
for the
The band goes up. Alright, so here it is, that's the preload, right? That is determined by the volume of blood coming, right? And then contractility, how much can it pump? And afterload is the pressure. Okay? And then this, I like this picture. So again, so if your preload increases, EDV increases, stroke volume increases, you can turn it, preload decreases, EDV decreases, stroke volume decreases. Same thing here, contractility increases, reduces ESV, right? Increases stroke volume. If contractility decreases, ESV is going to increase, and so on, right? So I like this picture. So So if you can understand this, again, here you have the afterload, this is ESV, this is EDV, right? So if afterload increases, what will happen to ESV? If this increases, if the blood pressure is high, this is high, this is going to be high, and this is going to
Low.
go down. Okay. You understand this? The other way. Alright, I'm having a hard time. So cardiac output is also controlled by nervous regulation. So epinephrine, norepinephrine, you don't need to know this. Okay, you can skip that. Okay, I wanted to talk about this. So the three ions, calcium, sodium, and potassium, all three are very important for the heart, function of the heart. Too much calcium, too little of any of these three is bad for the heart. Okay. High calcium is called as hypercalcemia. So it's going to start contracting way too much, right? Leading to irritability. Okay. Hypocalcemia is not going to contract enough, right? So calcium is directly connected to the contracting rate. Natremia, right? Sodium, too much sodium inhibits the calcium entry. So remember that depolarization that is taking place is not going to allow the depolarization of the autoreactive cells, right? So it's going to stop right there. Hyperkalemia, kalemia means potassium. This leads to hyperpolarization, right? So the more potassium you have, it is going to go down, 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 and it is going to interfere with the pacemaker potential, right? So the entry of sodium is delayed, so it really slows the heart down, right? So the more potassium you have, it is going to lower the action potential, leading to a heart block, okay? And it is going to stop working. Hypokalemia, too much, when you have too little, then it is just going to become arrhythmia. Okay, so you don't have enough potassium to hyperpolarize, it's going to go into resting membrane potential, right? And that's going to stop. Yes? Okay. So you do have to know this. Heart failure, now, I'm almost done. So, left heart, right? It is not able to, pump properly, so it's going to back up the blood into the lungs, okay? Right side is going to back up into the systemic circuit, right? It's coming from the systemic circuit, left side is coming from the lungs, right? So if this is not working, it's going to push blood back to the lungs. So left is the lungs, left, like LL, maybe you can remember that. Left side is not working, it leads to pulmonary congestion. Right side not working, it leads to peripheral edema. Okay, there will be a question on this, so don't get confused. LL, remember LL. LL Bean, LL Cool J. All right, so pericarditis, meaning inflammation of the pericardium, could be acute, could be chronic, right? If it continues, you have accumulation of pericardial fluid, may lead to tamponade, right? All those kind of problems. Cardiomyopathy, afterload is high, right? So it's going to put pressure on the heart. Infective endocarditis, that's mostly related to gum disease. Okay, if a person has gum disease, periodontal, or is it periodontal? Right. The same bacteria infects the inner lining of the heart.
What?
Alright, so take care of the gum, they can kill. So
Microbiome.
endocarditis,
Okay.
these two bacteria, this is the same that you have in gum infections. And that's the most
Crazy
common way of
crossover.
getting endocarditis, is having gum.
Well, we have problems from anatomy there too.
Yeah.
She's like,
So,
my anatomy people.
myocardial ischemia means lack of oxygen, that can lead to myocardial infarction, right, which is heart attack. Pericardial effusion, effusion means leaking, okay, so if there is fluid accumulation in pericardium, then it may leak. Septal defects, right, I have these septal defects in heart C, and the last slide, right, has ventricular septal defect or coarctation of aorta narrows, or tetralogy and fallow where all of them are open. Like you have the fossa ovalis not covered, ventricular septum is not covered, and you may have blood mixing between pulmonary artery and aorta. That's a very rare condition. I think it was Jimmy Kimmel. His son, his fourth child, he had tetralogy of Fallot. So these conditions, the heart septal defects, it's mostly in newborns, and it normally it gets, the heart is the last one to close right before birth, so sometimes it doesn't close all the way. Within few weeks it will close by itself. So they give about 6 months for them to close. If it doesn't close, then they go into it like surgically. They will close off. He had, and he survived. Right, so he had tetralogy of Fallot. I think it was severe. And we actually, I also thought that child would not survive. The survival rate is very, very low. But he still disappeared. I think it was, let me put
Oh,
it
so
in.
small. The baby hurts. Yeah, so small. I'm just thinking how they go in there and repair it when it's so tiny.
Yeah. His 7-year-old son had Hurdo. He was born with a condition called tetralogy of Fallot, with pulmonary atresia, severe heart defect that occurs in approximately 1 in some millions.
20-week fetus
I
heart
remember,
compared to
yeah.
the American.
So there.
That's
1 in
crazy.
2,500 babies. Okay. That's the end of this chapter. Let's see. This is a nice aorta, and this is clogged up aorta. Right. So this whole thing is a plaque, and this is a clot. Right, so instead of having nice round, so we have. Any questions? So don't sleep while you're taking the exam. I have had students fall asleep taking the exam. Yeah. Yeah.
Must be so tired.
Yes. Friday it will be open all day. So I am busy that day. I have, I had scoring day, so it's a system office thing. Okay. So I'll be busy, but I will be on my computer the whole time. So if you have any questions, just let me know.
And we'll have to do some calculations for stroke volume and cardiac output.
Yeah. And no calculators allowed.
What?
Yes. So.
You want us
these are
to you want us to
simple
raise this
mathematical
graphic?
calculations, so do it on paper.
Do you want us to like show you?
Yeah.
Oh, okay.
I would love to see that.
You can have like this paper, right?
And you'll be showing it in the video. Do you have like the end also you have to show, right?
Yeah, actually.
Yeah. There is one.
Yeah, I guess we should share paper.
Usually they just make us like take a picture of our paper and send it to them.
No, I think there is an option, I'm going to check that, where you can just show.
Yeah, I've heard of performance.
You're being required. Okay, so, and please, make sure that your camera covers at least till here, your arms, right? I have sometimes
Does that have to be
where
like
it
this?
is like this, just the eyes, okay? That's all I see. And I'm going to give a 0 for that. Okay, so there's no reason just to have your eyes.
All right, so
It will tell you.
right.
It says that the face is not visible, it starts screaming. So please pay
Ooh, I
attention to
can't even
that.
see the screen like that.
Because every time you're
Or I
flat,
can, but
can
it's just
see.
like distorted.
So that's when I go and check. Or if the grades, or if the answers are too AI, so be smart about it, don't cheat, first thing. 2, if you are cheating, be smart about it, don't just copy paste. Don't copy paste, and then fight with me that, no, that came from my brain. Really, you cannot make one sentence and
That's
you're
what I
writing
find funny.
like flowery words.
When people cheat, they don't even like switch up the
Okay,
wording.
so don't cheat.
See?
Because this time I've decided, like last year I had a student,
Yeah,
who
we
cheated
had-
the whole semester. It really broke my heart. And then I caught it. I had it down in the third exam. I check only when I'm grading a paper, right? And I was like, okay, this, and she was getting like 6 and 7 and like not even teens in lab exam and getting like 90s in lecture exam. That's weird. That's the first one. So first exam I said, okay, maybe she wasn't ready for that. Second exam, okay, there's a pattern here. Third exam, I knew. Yeah. And that's when I started looking at the free response questions. Fourth exam, I had already given the fourth exam. Final exam, I caught her. By that time, she had become very complacent that I'm standing here. She's sitting right there and had the phone right on top. How stupid can you be? So she had
In
become that.
person.
In person. I'm talking about in person.
That's crazy. I would be
it-
so paranoid.
So this online crap, the online classes, that's what it has done to you guys then. You know, it's so easy to cheat. That's become a habit. So get rid of that habit. It's okay to fail 1 or 2 classes.
Is it open till midnight?
I have no idea. So. be
You should
careful.
push it for Saturday.
Do not,
No,
do not
no.
have anything on you. Don't depend on that. If you feel that's okay, but the.
Wait, with the exams, the timeline is open till midnight.
Do you want me to open at 7 AM? Anybody wants to take at 7? I can open it. I'll open it from 7 to.
I'm still sleeping
Even
at
till
7.
1 AM would be fine.
Okay. Are you taking it in,
Well, I have some other stuff due on Friday, and then I have a doctor's appointment for my dad, so I'm probably gonna find out.
So come and talk to me. I can open it because I had a student in my morning class, he works on Friday, so he wanted me to open it till 2 AM or 3 AM.
Yeah,
So
then-
take it on Saturday, yeah, let me know the time, I can open it. Email me. Okay, so special circumstances,
You
email.
sure you wanna email?
Email.
Okay.
Email. Or you can tell her, because I'm not going to be meeting you now, right? So
Okay, yeah.
that's-
Wait, so I'm just
How
telling you
about
that.
you now? Yeah. Midnight. So I don't want to lose the piece of paper, but yeah, let me know, okay, so that, I write down.
So how, for regular on Friday, how late will it be open? Like if,
Let's just open it for everybody to see.
Midnight.
Midnight?
Midnight is 11:59 PM. Okay, don't say that, I started, oh, this is my favorite. So I get, my online classes, I mean, we should really